Good day, everybody. I am Dr. Raymond Oliva, and I am the Medical Director for Astellas Philippines. Our speaker for today is a very esteemed physician and a very highly respected OBGYN. She is the head of the Urogynecology and Incontinence Center of the Makati Medical Center and the section head of the Urogynecology and Pelvic Reconstructive Surgery of the same institution. She underwent clinical and research fellowship of urogynecology and pelvic reconstructive surgery at the Mount Sinai Hospital, University of Toronto, Canada in 2004 and 2007, and she's presently a board member of the Philippine Continence Society. Doctors, our speaker for today is no other than Jennifer Marie B. Jose.
Good afternoon. Thank you, Astellas, for that kind introduction. My topic this afternoon is Mirabegron as the first-line pharmacotherapy for overactive bladder patients, insights from clinical data. For disclosures, I'm a speaker and advisory board member of Astellas Pharma. Okay. The contents. So first we talk about the introduction of overactive bladder. Look at the OAB prevalence, okay? Based on population-based studies, OAB prevalence rates range from, look here, for men, we have 7 to 27%, and for females, it's 9% to 43%. Overactive bladder prevalence is similar across gender, and OAB prevalence is estimated as being similar across regions, with the prevalence in Asia being slightly lower compared to Europe. OAB symptom prevalence and severity tends to increase with age. The majority of patients have symptoms for years. Okay. Look at the OAB symptoms impact on the quality of life of patients. 92% of patients report a health-related quality of life reduction following the onset of OAB symptoms. And those patients with urinary incontinence are less likely to be in paid employment and have greater productivity loss compared to those who have continence. Okay. What are the treatment options for overactive bladder? Let's start with behavioral treatment. This is actually the first line treatment, okay? So what do? We give fluid management. We limit the fluids to 2.5 to 3 liters a day. We have bladder training. We have to teach patients to toilet by the clock. What is a normal voiding is actually voiding every 2 to 3 hours. We have to teach patients how to do bladder control strategies. These are actually urge control strategies, trying to hold the urine for 1.5 to 2 hours, okay? So that would be like training the bladder and the urge control as well. And then we also do the pelvic floor muscle training. What is this? This is actually the right Kegels exercise, and we do this 10 times in the morning, 10 times at lunch, and 10 times at dinner time to actually strengthen our pelvic floor tone, okay? Then after, we go and do the pharmacologic management. What are the medications available? We have the antimuscarinic medicines, and we also have the beta-3 adrenoreceptor agonists. Of course, hopefully we're able to treat the patients after giving this pharmacologic treatment. But if ever the patient still have these symptoms, we can actually resort to the Trusor botulinum toxin injection. We can also do peripheral tibial nerve stimulation, sacral neuromodulation, and also in rare cases, we have the augmentation cystoplasty or urinary diversion. Okay. Now we go on to the overactive bladder management guidelines and clinical data. Now, The International Continence Society also has recommendation. And what do we see here? They have recommendation for men, and they also have recommendation in women. In men, antimuscarinic or beta-3 agonist drugs for OAB symptoms with or without urgency incontinence if the patient has no evidence of significant post-void residual urine. Alpha adrenergic agonists or alpha blockers can be added if it is thought that there may also be a bladder outlet obstruction. So we have to know the post-void residual urine because remember, when we relax the bladder, okay, and you have a lot of residual urine, we're actually going to make the condition worse. So it's good to check. For the recommendation in women, antimuscarinics, beta-3 agonists for OAB symptoms with or without urgency incontinence. So you can see that these medications are actually good for both men and women. Okay. Now, there is a BELIEVE study. It's a European real-world study of Mirabegron in overactive bladder. And this is actually conducted in 12 months. It is a prospective, non-interventional study. And this is conducted in 8 European countries in patients with overactive bladder who were prescribed Mirabegron in clinical practice. Okay. So here we're talking about the quality of life. So the patients that are included here are those adults with overactive bladder symptoms. And for the full analysis set, we have 796 patients. 74% are actually females. 48% are more than 65 years of age or equal to 65 years of age. And 42 patients are actually treatment naive. And look at the primary objective of this BELIEVE study is you would like to see the change from baseline in quality of life based on OAB question subscales. Okay, so what do we see here? Okay, in this BELIEVE study, we can see that Mirabegron treatment resulted in clinically meaningful improvements. Okay, so here we can see that the quality of life improvements were observed from baseline in patients less than 65 years of age and those more than 65 years. And the persistence is actually 53.8% for patients who were still receiving Mirabegron at 10 to 12 months. So they were actually assessing patients from 2 to 4 months and also from 10 to 12 months. And in terms of symptom bother, and also by looking at the health-related quality of life, we can see that there is actually improvement in time. So from 2 to 4 months, if they compared it to the 10 to 12 months, and there is actually a big improvement. Okay. So this BELIEVE study also showed the adverse events that were consistent with the known tolerability profile of Mirabegron. Okay. And what do you see here? Look at the adverse events. But they are actually very minimal. Look at the percentages, right? And they have like 363 patients here. This is another study. We have the PREFER study. It looks at the tolerability and patient preference of Mirabegron versus toltoridine in OAB. Okay, toltoridine is actually an antimuscarinic drug. It is a multi-center in US and Canada double-blind randomized 2-period crossover phase 4 study in the treatment-naive adult patients with overactive bladder. So here you can see that those who were given Mirabegron for the first 8 weeks, and then after 2 weeks washout, in the second succeeding 8 weeks, they were shifted to toltoridine. And then you can see that there's another group given toltoridine first, and then after 2 weeks, they were given Mirabegron. And then another one, we have Mirabegron 50 milligrams given for 8 weeks, and then after 2 weeks, wash out. In the second week for an 8-week treatment, we have the Mirabegron 50 again. So you see they change, and they have like, they want to see what is the tolerability of these patients, okay? And what do you see here, okay? So look at the primary outcome, OAB medication tolerability score. So from a score of 0 to 100, with a higher score indicated better perceived OAB medication tolerability, meaning less bother from the side effects, okay? And they are actually comparing Mirabegron from tolterodine. We can see that the Mirabegron has the higher value. So it means that it is actually more tolerated by patients, okay? Now, there is actually improvements were actually more evident in women, it was stated in this study, and patients more than 65 years of age, and those in patients without baseline incontinence. Okay. Now, look at the treatment emergent adverse effect. And I'd like to center more on the more common adverse effect. And these are actually comparing those patients who were given Mirabegron and those patients who were given tolterodine, okay? And look at the difference. We are looking at the dry mouth, constipation, and headache. And if you compare the values, you can see here that it is really more tolerated by patients who took Mirabegron because they have the least side effect compared to tolterodine, which is also an antimuscarinic medication. What do you see here? Okay, again, we can see here that the values for the Mirabegron in terms of the adverse effects is actually less compared to those who are taking tolterodine. Okay, now look at this preferred study again, the patient-reported outcomes in terms of the percentage of responders achieving more than 10-point improvement in OAB symptom bother score, total health-related quality of life, and OAB health-related quality of life subscales, okay? What do you see here? The red ones is actually the Mirabegron, and the fuchsia ones, okay, are those who took tolterodine, okay? So you can see here that the responders, you can see here that for Mirabegron, okay, they are actually almost the same, but more improved in terms of like the values for Mirabegron. Okay. Now, this is a study on the safety efficacy of the overactive bladder drugs. It is a pooled data analysis of clinical trials. Okay, so here we have like a 10-phase, 2 to 4, double-blind, 12-week study, and we have those who had placebo, Mirabegron, solifenacin, and tolterodine. So it's like saying they got different anti-cholinergic medications as part of the study, and they wanted to see what would be the difference in terms of the result when they compare it with Mirabegron. And look at the patients who have overactive bladder, okay, they have a big number. It's around 11,261, and the mean age is actually 57.5 years. Okay. So again, what do you see here, which is actually very, you know, how do you say it? It's like very pronounced complaints of patients, right? So it's actually dry mouth, right? And what do you see here? If you compare Mirabegron from all the antimuscarinic medications, it's actually a big difference in terms of the number of responders. Like, look here, you can see that we only have 2.7 for Mirabegron, and for the antimuscarinics, it's 8.7. That's why, in terms of safety and tolerability, you know, a lot of people, a lot of patients with overactive bladder respond very well with Mirabegron. Okay. Look at the common treatment emergent adverse events, okay? And they have actually spread it out and divided it for those who are less than 65, more than 65, less than 75, and more than 75. What do you see here, okay? The most problematic concern, okay, or the bothersome concern is actually the dry mouth, okay? And this also happens among men, so it's not only for females. But here, what do you see here? Okay. Now, you can see here that they are trying to classify patients based on age, like less than 65, more than 65, less than 75, and more than 75. And what can you see here? You can see here that, look, it's really those who are taking antimuscarinics are the ones who are actually complaining of dry mouth, right? So I think it is the dry mouth and also the constipation are the two things that is actually very bothersome, and the usual complaints of patients taking antimuscarinic drugs. And that's why they are also, I'm trying to see if those who are taking Mirabegron also has the same complaint, because I think that is the main reason based on all these studies. That's why, a lot of patients would prefer taking Mirabegron because they feel that they don't have any side effects. Okay. So Mirabegron in overactive bladder management, beta-3 agonists are recommended as the first-line treatment of overactive bladder with or without urge incontinence in both men and women. The placebo-controlled RCTs have shown Mirabegron monotherapy to significantly improve overactive bladder symptoms in both men and women with no significant adverse events compared to the placebo. In some clinical trials, mirabegron has similar efficacy compared with antimuscarinic agents, but it has a lower incidence of antimuscarinic adverse events, including dry mouth and constipation. So now we go to the overactive bladder management in subpopulations. Remember, I've mentioned to you earlier that majority of patients with overactive bladder are the elderly population. And we have this pillar study. So this is a like a usual case that we see in the clinic. We have like an 81-year-old female patient, and this is the complaint of the patient. They have symptoms of urgency. They have that symptom 7 times in a day. Frequency, they go to the washroom 12 times a day. They have urge incontinence. They don't make it to the washroom. They leak before getting there 4 times a day, and they get up 3 times at night. Now, with a medical history, this is a gravida 2, parent 2, who had a hysterectomy for benign disease. This patient is known to have type 2 diabetes mellitus and is actually controlled on metformin. She has allergies and managed with cyproheptadine on a PRN basis. She has Parkinson's disease and treated with amantadine hydrochloride, and this patient has a mild cognitive impairment. Okay, so this has increased cognitive issues with anticholinergics for overactive bladder. Okay. Look at the EAU 2020 guideline. Okay. So look at the recommendation. Long-term antimuscarinic treatment should be used with caution in elderly patients, especially those who are at risk of or have cognitive dysfunction. Okay. And this is actually a very strong recommendation, because look at the anticholinergic load. In older people, the cognitive impact of drugs which have anticholinergic effects is cumulative and increases with the length of exposure. Clinicians should use caution in prescribing antimuscarinics or beta-3 adrenoreceptor agonists in the frail OAB patient. Clinicians must use caution in prescribing antimuscarinics in patients who are using other medications with anticholinergic properties. So look at this slide over here. Mirabegron has demonstrated efficacy versus placebo in patients more than 65 years of age with overactive bladder. And if you are going to look at the number of incontinence episodes, okay, and this is a study with a pooled 12-week analysis, and you can see that when you look at for all patients and those who are more than 65 and those more than 75, if they compare those patients who took Mirabegron compared to the placebo, you can see that the number of incontinence episodes is actually improved. Okay. Now, in this pillar study, this is a prospective RCT of Mirabegron in patients more than 65 years of age. And the enrolled patients experience more than one incontinence episode, more than three urgency episodes. They have more than 8 micturations per 24 hours. And this is actually written in their 3-day micturation diary, okay? This is actually a phase 4 double-blind multi-center study. And what they are looking at here is that some were given 25 milligrams of Mirabegron and some were titrated to 50 milligrams at week 4 and also on week 8, okay? And the treatment period was actually 12 weeks. So that is equivalent to 3 months. And look at the primary endpoints: change from baseline to end of treatment in mean number of micturations and incontinence episodes within 24 hours for Mirabegron with the use of a 25 or a 50 milligram medication of Mirabegron versus placebo. And what do you see here? You can see that those who took Mirabegron, as seen among those who are 65 years old and older, you can see that the incontinence episodes within 24 hours is actually reduced, right? And even the mean number of micturation within 24 hours is actually reduced. So patients with zero incontinence episode, okay, at the end of treatment, look, Mirabegron, the total is actually 38% compared to placebo, which is 30%. So you can really see the improvement among patients. Okay. So in this pillar study, you can see the most frequent treatment emergent adverse event, okay? So if you are going to compare the placebo and Mirabegron, what do you see here, okay? Look at the side effects for those between 65 to 74 years of age to those more than 75 years of age is actually less, okay? And these are actually something that, it's not really that bothersome. It can be handled. Okay. Now, in terms of cognitive assessment, remember, this is actually a big issue among the elderly population. They use the Montreal Cognitive Assessment Scale, okay, which is a one-page 30-point screening instrument to detect mild cognitive impairment. And what do we see here with this pillar study? That there is no statistically significant change on cognitive function after 12 weeks treatment with Mirabegron. Okay, it's almost the same. So there is no issue in terms of the cognitive function. Okay. Now we go to persistence and adherence. Okay. So this is based on the EAU 2020 guidance. Look at the summary of evidence. Adherence to antimuscarinic treatment is low and decreases over time because of lack of efficacy, adverse events, and or cost. And most patients will stop antimuscarinic agents within the first 3 months, okay? Now, look at this study over here. This is actually anticholinergic cycling in patients with wet overactive bladder. This is a retrospective claim analysis in California. What is important here is that the urge, incontinence, symptom burden, and adherence to therapy did not change as patients attempted more anticholinergic therapy. So you can see here that, even if the patient keeps on adding and adding more anticholinergic medications, okay, they continue and they discontinue, the urge, urinary incontinence symptom burden did not actually change. But look at the this slide over here in terms of persistence and adherence with Mirabegron. This is a post-market experience in the United Kingdom. And if you're going to look at the slide here, it's a time to discontinuation of Mirabegron versus tolterodine, ER, and other antimuscarinic medications. Okay. Patients receiving Mirabegron remain on treatment for significantly longer and have significantly better 12-month persistence and adherence rates compared to tolterodine ER and other antimuscarinic commonly prescribed for OAB in the UK. Okay, so patients are actually continuing the treatment because, of course, the less side effect, and they're actually very comfortable. Okay. This slide shows persistence and drug switching. This is a retrospective medical chart-based study in Japan. And we have 777 patients, it's quite a lot, more than 18 years of age who underwent antimuscarinic or beta-3 agonist therapy at the Kitano Hospital in Osaka. And what can you get from here? We can see that older patients, male patients, and those with more severe urgency symptoms are more likely to show treatment persistence. And treatment persistence with Mirabegron was significantly longer than that with antimuscarinics when administered as either the first or second line medication. Now look at the real world persistence and adherence to overactive bladder drugs, okay? This is actually a systematic literature review in 30 studies, okay? And what do you see here, okay? With regards to the medication type, 79% of studies reported medication type as a determinant of persistence, and greater persistence was reported at 1 year with Mirabegron, 32 to 38% versus antimuscarinics, 8 to 25% in 3 studies, okay? And the older age and the female gender were also associated with greater persistence. So in summary, okay, we can actually conclude from 3 clinical trials, like in the general population, based on the BELIEVE study, that patients with overactive bladder symptoms receiving Mirabegron in a real-world setting reported meaningful improvements in terms of quality of life, with a persistence rate of 54% at 12 months, and the adverse events were consistent with the known safety profile of Mirabegron. For the PREFER study, the tolerability of Mirabegron was significantly higher than that of tolterodine, and patient preference and improvements in OAB symptoms were comparable. Both treatments were well tolerated. So for those in subpopulations more than 65 years of age with OAB and urinary incontinence, okay, we discussed the PILLAR study, and here we can actually conclude that Mirabegron's efficacy, safety, and tolerability over 12 weeks was confirmed in patients more than or equal to 65 years of age with OAB and urinary incontinence, and treatment with Mirabegron for 12 weeks did not contribute to drug-related cognitive side effects in patients more than or equal 65 years as measured by the MOCA. So look at the safety profile of Mirabegron. In terms of gastrointestinal safety, we always have to emphasize this because this is the reason, one of the reasons that's why patients continue taking Mirabegron is that the incidence of dry mouth and constipation is actually low. In terms of urodynamic safety, there is improvement in mean number of micturations in 24 hours and mean volume voided per micturation in male, lower urinary tract symptoms, and the incidence of urinary retention is low. And in terms of anticholinergic safety, There is no significant adverse impact on the cognitive function in elderly patients, and there is no significant evidence of increased risk for narrow angle glaucoma. Thank you for your attention.